I can, yes.
Okay, good. All right. Well, it's always good to talk after someone who's a lot smarter than you. So I have to follow Dr. Nixon and Dr. Albers. So that's great. But we're going to talk about congenital scoliosis. This is completely different than adolescent idiopathic scoliosis. So, disclosure, sadly, I don't have any. The natural history of congenital scoliosis. The spine develops during the first 6 weeks of the embryologic phase, and it's caused by a developmental defect in the formation of the mesenchymal onlog. There's no evidence of genetic inheritance. The spine normally grows from the superior and inferior end plates of the spine, which I'll show you a picture of shortly. And then if you have a disc space that's normal, then that usually means you're going to have normal growth. And if you have a disc space that's not normal, then that probably means that it's not going to grow appropriately. And we'll get into that as we classify congenital scoliosis. And then the behavior of the curve. So depending on whether the curve is going to get worse or not, depends on where the curve is and what type of congenital scoliosis the patient has. The causes are usually idiopathic. That's usually the most common cause, but it can be caused by diabetes, alcohol use, seizure medicines like valproic acid, and hyperthermia. The number one associated condition with congenital scoliosis is VACTERL. It's formerly known as Vater syndrome, but it stands for vertebral malformations, anoatresia, cardiac malformations, tracheoesophageal fistula, renal or radial anomalies, and limb defects. Around 60% of people who have congenital scoliosis are going to have some other organ involved. So that's the most important thing, that you need to look for something else. 10% of the time it's going to be heart related. 25% of the time it's going to be GU related or genitourinary. And then oftentimes you're going to have another spinal cord malformation. So the biggest thing is if you have congenital scoliosis, you're at a high risk of having another spinal problem. So you definitely must get an MRI in a patient who has congenital scoliosis. The classification, it's really broken up into two different classes, and then those two can also be mixed. But the first is failure formation. So it can be complete or incomplete. It can be fully segmented. So what that means is you can have a disc space above and below. If it's partially segmented, you'll have one normal disc space either above or below, and one disc space that's not normal. So it's probably going to be fused above or below. And then unsegmented is where it's going to be fused above and below. And we'll show you a picture of that shortly as well too. And then the other one is failure of segmentation. And then lastly, you can have a mixture of those two. So this is what you'll see with failure of formation. The first and probably the best is the wedge vertebra. And that's where you see in the picture A over there, it's incomplete formation of the vertebra. So normally the vertebral body should be block shaped. It should not be wedge shaped. But what you'll notice when it's a wedge, it's going to be higher on one side than the other. It's smaller than a normal vertebral body, but it still has pedicles. So hopefully my arrow is working, but these circular things right here, these are called pedicles. And so you can see in this wedge vertebra, this patient still has two pedicles, but the vertebra itself is smaller. Then you can have what's called a hemivertebra. A hemivertebra, you're only going to have one pedicle. This is a fully segmented hemivertebra. This is where we talked about earlier, but this is a normal disc space above and below this vertebral body, this hemivertebra. That actually has a lot of growth potential because anywhere you have a disc space, you're going to have growth. And when I talked about the superior and inferior end plates, the superior and inferior end plates is the top and bottom of this vertebral body. That's where all the growth is. So if you look at C over here, this is a partially segmented hemivertebra. There is no disc space above, but there is a normal one below. So this is going to have less progression of growth than B is going to have. And then if you look at D, that's an unsegmented hemivertebra. That's where it's fused above and below. And that actually has a less likelihood of progressing if you have that hemivertebra. And this is a picture of a patient of mine. And you can see that this is a hemivertebra here, and it's definitely segmented above. And it's hard to tell if it's segmented below, but it's definitely segmented there as well. Failure of segmentation, this is a little bit different. So this involves bony bars between adjacent vertebrae. So if you look at A, this is one big vertebra, even though it should be two vertebrae, and it's bilateral. So you have bilateral defects produces a block vertebra. This itself usually does not cause much scoliosis, but it is important to know if they have a block vertebra, they may have some other abnormality in their spinal vertebral column as well. And then B is a unilateral defect. So you can see that it's fused on one side and not fused on the other. And so this essentially creates a tether. So the right side of this vertebra can grow, but the left side cannot. So that will create a scoliosis. And then you have C, and this is the worst kind to have. So what you have is you have a hemivertebra that's fully segmented. So it has a disc space above and below, but on the other side, it has a bar. And what happens is the bar doesn't grow, but the hemivertebra does grow, and that continues to get worse. And that is when you really need to watch these closely, because these curves can get out of control. And so here's just an x-ray to kind of show you this hemivertebra in the lower thoracic spine is unsegmented. So there's a disc space above and below, but there's not a bar. So there is a risk that it could progress, and it will progress, but not as much as some of the others. And then you have this block vertebra below, and that block vertebra probably is not going to progress near to the magnitude that the hemivertebra would progress. So not all congenital scoliosis is created equal. And then this is not part of the classification, but the spine is broken up into three columns. You have the anterior column, which is the front, that's the vertebral body. You have the middle column, which includes usually the pedicles and the spinal cord. And then you have the posterior column, and that's the part when you feel your own back that you can feel. That's where the spinous process is. But oftentimes in congenital scoliosis, the spinous process may be abnormal. So normally it should be one confluence that you can feel on the back, or it can be bifid where it doesn't actually connect in the middle, and it has two little areas or two little prominences coming off. You could have a fused lamina, so that's where the different levels will be fused to the so when we showed you a bar in the front, this is essentially but it's a bar in the back. And then oftentimes you can have exposed spinal anatomy. So if you're missing bone in the back when you're doing surgery, you need to be aware, because the spinal cord may not actually be covered by bone. So that's why it's so important that you always get MRIs and CT scans before you operate on these patients. Progression, once again, it depends on the anomaly in the location of the curve. If it is a thoracic, it's less likely to progress. If it's lumbosacral, it's going to progress slightly more, but thoracolumbar is where it's really going to progress a lot. And that's because you have a lot of growth between the thoracic and lumbar junction. If you have fused ribs in the thoracolumbar junction, then that usually means the deformity is going to be worse as well, because that adds to that tether effect. And if it's mixed, then it's really unpredictable. Sometimes you'll see patients who have 3 or 4 hemivertebras, and they all balance each other out, so they really don't end up having a big curve. But you really need to pay attention to the thoracic cavity as well, because if you do have fused ribs, you can get something called thoracic insufficiency syndrome, and that's essentially where the thoracic cavity cannot expand, and that causes impingement in their lungs, and they cannot breathe very well. You really want to watch these at different periods throughout their life, but usually the first 5 years of life is when they're going to grow the most, and then after the adolescent period, they're going to progress as well. And I have a picture to show you later on where, early on it may only be like a 30 or 40 degree curve, but once they start to hit their adolescent growth spurt, it's going to exponentially progress. And this is just a rule of thumb, and just like anything else in medicine, you can use this, but there's some that's going to meet these rules and some that's going to be a lot worse. But if it's a block vertebra, you're probably not going to have too much progression, which is good. If it's a wedge vertebra, it's pretty similar to a block vertebra. It's just a little bit smaller. Hemivertebras, that's where you're going to have significant progression, 2 to 5 degrees per year. And so if you're an infant and you have 5 degrees, and after age 10 you're going to be at 50 degrees, and then by the time you're 16, it's going to be a very big curve. If you have a unilateral bar, that is going to be 5 to 6 degrees. And then if it's a unilateral bar with a contralateral hemi vertebra, once again, that's always the bad one. Those are the ones where, you know, sometimes you'll have a 2 or 3-year-old with a 100-degree curve already. Physical exam is very important for congenital scoliosis. You want to always check the abdominal reflexes. So what you do is you want to take metal. If your pin tip is metal, that's good. But in each quadrant of the abdomen, you should stroke towards the umbilicus. And if your belly does not move, then that is an abnormal abdominal reflex. That in itself may not mean anything, but if you see that along with some other signs, that may be a sign that there is something wrong with the vertebral column. There may be some spinal neural axis abnormality, like a tethered cord, syrinx, a hydromelia, things like that. You want to check for root tension signs. So if they have a positive straight leg raise, or if they have very tight hamstrings, they have clonus, things like that, that could be a sign that they have a tethered cord. Anytime you see a hairy patch or a cutaneous hemangioma, that is a sign telling you that the anatomy under that skin is not normal. And so whenever you see something like that, you need to get an MRI. Oftentimes they'll have truncal or pelvic obliquity. A lot of times they'll have foot deformities as well. So they may have club foot, and they have a higher association of a vertical talus, which is essentially club foot on steroids. And then all of these requires an MRI. And the important thing is, if you see, and insurance companies try and push back on us, but if you see something in the lumbar spine, but they have congenital scoliosis, you need to get an MRI from the sacrum to the posterior fossa, because at any area along that spine, they could have an abnormality. And so always start out with x-rays for your imaging, PA lateral. If they can do standing, that's the best, obviously. If they can't, then supine's fine. You always want to measure the Cobb angle, which we've talked about extensively. But anytime you're going to progress to surgery, you want to make sure to get a CT scan, because that shows you exactly where things are fused. An MRI is a great study, but it's not the best study for bone. CT scan is the best study for bone, but you need an MRI as well, because if they have a tethered cord, if they have a syrinx, if they have a hydromelia, any other spinal neural axis abnormality, most likely that will not be seen on a CT scan, and you'll need an MRI. It's very common to have kidney problems with congenital scoliosis as well as heart problems. So you want to get a renal ultrasound. And now they're really pushing any patient that has congenital scoliosis should probably have an echo before surgery. Keep throwing out this term neural axis abnormality. That is just a term that could mean any of these: a Chiari malformation, a tethered cord, a syringohydromelia, a diastematomyelia, an intradural lipoma. I know those are big words and I'm not really explaining them very well, but that's really more for a neurosurgeon or a radiologist to explain. What I explain to people is I operate on the bone part of the spine. I don't operate on the spinal cord part of the spine. I do think it's my obligation to find that abnormality, but it's not my obligation to treat that abnormality. Because if they have one of these spinal neural axis abnormalities, it must be treated before you operate on the bone part of the spine. Non-surgical management is really just observation. Bracing does not really help with congenital scoliosis, which is different than adolescent idiopathic scoliosis or even juvenile idiopathic scoliosis. Those are usually muscle and balance problems. Congenital scoliosis is a bone problem, and you cannot fix a bone problem with a brace alone. Now, you can use bracing if the patient has what's called a compensatory curve. So if they have a curve above or below where the hemi vertebra or the wedge vertebra may be, then it may help slow the progression of that curve, but it will not actually treat the congenital scoliosis itself. Surgical management goal is going to be to obtain a balanced spine while maintaining flexibility and preserving as much normal spine growth as possible. And so if someone has a hemivertebra and they have a big curve, you don't want to fuse the whole area where the curve is, because a lot of times you're operating on young kids, and if you do a 6, 7, 8 level fusion in a child that young, their spine cannot grow. So the idea is to remove that offending area and fuse just a small portion and allow the spine to essentially continue growing. Now, if there is predicted progression, that's when you're going to proceed to surgery. And if they have an anomaly that you know is going to progress, like what we showed earlier, and it's always important, anytime you're doing a spine surgery in kids, you should really have neurological monitoring in the surgery. But for congenital scoliosis, it's very important because they do not have normal anatomy. And you just manipulating their spine is not going to be handled as well as a normal child with adolescent idiopathic scoliosis. And the different surgical options is an in situ fusion. And so what that means is you're not taking any of the congenital anomaly out. You're just fusing the spine exactly where it is at the time. You can do osteotomies, and osteotomy is a fancy name for cutting the bone. You can do segmental vertebral excision. That's where you actually take out whatever the problem is. And we'll go into these in more detail. There's growing rods, and then there's something called vectors, which has kind of fallen out of favor, but there is still one true indication for that, and that's vertebral expandable prosthetic titanium ribs. So the indication for surgery is if you have a rapidly progressing deformity. So once again, if they have the bar on one side and a hemi vertebra on the other side that has a normal disc above and below, then you're probably going to need to proceed to surgery at some point for that child. And if they have significant truncal imbalance, I think that's what you'll notice with these kids with congenital scoliosis, because their curves are not regular idiopathic curves, and so they may be trunk shifted. So when they're standing, their trunk is shifted to one side significantly than they would be if they had a flexible scoliosis curve. So the cervico-thoracic and the lumbosacral junction usually causes more of those truncal imbalance as well, even at smaller degrees. So an in situ fusion, that's where we talked about you have a deformity and you're just going to fuse it right where that is. And when you would do this is before a major deformity is present, or if you think the deformity is in an area where it's too dangerous to maybe take out the deformity. So if they have a unilateral bar with a contralateral hemivertebra, usually boys older than 12 and girls older than 10, because if you do it younger, then you can get something called crankshaft phenomenon, and that's where the back part of the spine fuses, but the front part of the spine doesn't, and it continues to grow, and it can't grow up or down, so the spine grows around like a crankshaft. And there's not really a treatment for that, so you want to be careful on exactly what surgery you choose for these patients. Usually you do it from the back. You want to, if you can, you just want to do one level above, one level below, and depending on your fixation, you may need to use a cast. And then you can do it from the front as well. And this will help prevent the crankshaft phenomenon. But if you go through the thoracic cavity, you may decrease some of the lung capacity, but you want to be careful to stay away from the segmental arteries because that helps supply the vertebral column. But we talked about this with Dr. Meyer earlier today. Anterior surgery is becoming more of an option, but we're still in the early phases of it. And so this would be a good example of when you would want to do an in situ fusion. So this boy's 11, and he has a hemivertebra, as you can see up there, and he has a contralateral bar. And his curve right now is only about 35 or 40 degrees, but that's going to continue to progress. But that is a very risky area to remove a hemivertebra. That's up there around 1, 2, 3. That's around T3 and T4. You get close to the aorta, the azygous vein. There's a lot of red and blue looking vessels in that area that you really do not want to get into. And so I think that's a little more dangerous. And the more proximal you are, the less manipulation the spinal cord can handle. And so this may be one where you would want to fuse it in place as opposed to taking out the hemivertebra, as I'll show you on another case. But one thing I want you to notice is you can see sternal wires in here. And so anytime, this is what we were talking about, is anytime you have a spinal abnormality, they may have another abnormality too. So, they always kind of go together. And so a hemivertebral excision This is a high neurological risk, so you got to make sure you have neuromonitoring. And this is actually better to do when they're younger, around 3 to 5 years of age. If they're younger than 3, then their bone is really small and their skin is very thin, and it's really hard to use instrumentation that's not going to be prominent. Dr. Meyer and I had to do a 100-degree curve patient, and who we just couldn't wait any longer. They were only 2. We had to do a hemi vertebral excision on, and they did very well with surgery. But the biggest problem we had after surgery was the fact that the hardware was so prominent that we had to have plastic surgery, kind of revise the incision, and we're actually having to take the hardware out, even though we used cervical instrumentation, which is the smallest instrumentation we could have used. But this is usually better on the lumbar spine. Number one, the spinal cord can handle more manipulation in the lumbar spine. And so if you see here, this patient, when they were younger, their curve was, only about 25 degrees. And then as they started to get older, that curve started to progress to over 45. And then there's a more recent x-ray showed it was actually over 50 degrees. And so here you can see the CT scan shows us that, it's segmented above, but it's not segmented below, but there's a bar here. So this girl was only 11 years old. It's going to continue to progress. So what you do is you take out the hemivertebra and then you fuse above or below. And so if you want to be critical and look at this x-ray, I would say, yeah, that the spine is not 100% straight now, but we only fused 4 levels. We got at least half correction, and now we allow her spine to continue to grow. And so I do think hemivertebra is a very good surgery in the correct population. And so you can do less if you don't want to do a true hemivertebra, because it is such a big surgery. You can do some osteotomies where you just try and make the spine more flexible, and then you fuse the spine. You want to be careful though, especially if there's kyphosis. So regular scoliosis patients do very well when you translate their spine. But if you have kyphosis, the spinal cord almost hugs the posterior column of the spine. And so when you go to straighten out that spine, the spinal cord almost gets pinched. So you really want to do your correction very slowly, and you want to be very careful because you don't want to, obviously you don't want to take a patient that could walk before surgery and make a patient that can't walk after surgery. And so that's kind of the same thing here. Just a different wording. And then growing rods. This is some of these patients where maybe they have congenital scoliosis. The curve is not at the point where we need to do an excision, and it's not at the point where we want to fuse it, but they're so young that we want to get a hold of it and allow them to grow. So this is where growing rod comes in. Growing rods is where you will anchor above in the thoracic spine and below in the lumbar spine, and you can essentially lengthen the rods as they grow. The traditional growing rod had to go in and have surgery every 6 months and lengthen it. And now we have something called a magic rod. A magic rod is actually a magnetic rod that you implant the same way as a regular growing rod, but instead of having to go in and do surgery every 6 months, you can actually lengthen it in the office with a magnet. It's painless. The biggest problem with the magic rod is the name. It's not magic. When they looked at the studies, the complication rate is pretty much the exact same with a traditional growing rod as it is with a magic growing rod. Now, they did have to go have anesthesia less times, but it's still not without complication. I think that's the most important thing to explain to the family, that yes, it is a better option, but no, it is not a perfect option. If someone has congenital scoliosis, they do not have a normal spine. We can do everything in our power to help that spine, but it's never going to be a normal spine, even if it is straight. And then lastly, thoracic insufficiency syndrome. I'm showing this to discuss what a vector is, but this is severe congenital anomalies of the spine that make it impossible for the thorax to allow normal lung growth and respiratory function. And so the treatment of this is the Vector, which is a vertical expanding prosthetic titanium rib. And so if you look on this picture on the left, you can see where these ribs are clumped together and they're actually fused. And so doing a Vector, you can go in and break up this fusion, and then you put a construct on the rib. So as opposed to actually putting it on the spine, you can do a rib to rib construct, which is this one on the left, or you can do a rib to spine. But the idea is that just like the traditional growing rods, you go in every so often and you lengthen that, and hopefully that expands the thoracic cavity. But this, once again, is not without complication. If there's anything that you can learn from this talk, number one, is that congenital scoliosis is very complicated and that there's always going to be complications. These are very big surgeries that we offer here in Louisville. They don't need to go out of the city for them. They don't need to go out of the state for them. But I think the most important thing is that the families need to have realistic expectations, because if you have congenital scoliosis, it's not usually going to be a one and done surgery. It's going to be multiple surgeries over their lifetime. But we do certain things to help prevent complications. But the biggest thing is try not to over distract, try not to overcorrect, try not to disrupt the blood supply to the spinal cord, and always have neuromonitoring changes. Because in a typical adolescent idiopathic scoliosis case, very rarely are you going to have neuromonitoring changes. And I would say in a congenital scoliosis case, it's probably, upwards of 30% of the time you're going to have some neuromonitor changes where you either going to have to do less correction than you would like, or you're even going to have to, unfortunately, abort the surgery because the spinal cord cannot handle any more that case. Any questions?
Thank you, Kent. That was very informative. I don't see any questions